So at the outset, I would like to thank the organizers for giving me this opportunity. I would like to thank PSYOP Asia, PSYOP as the whole body itself, and the Pediatric Hematology Oncology Chapter of India, and the organizers of this meeting. So today I've been asked to speak on medulloblastoma in the young, and it is indeed an honor to be sharing dais with all these senior people who actually have reformed the way we look at pediatric neuro-oncology. Medulloblastoma in the young, or traditionally called the infant medulloblastoma, have been defined variably. Children with medulloblastoma, whose age is from 3 to 5 years, less than 3 to 5 years, invariably are the challenging patients, and these are the patients who require specialized care. This subgroup poses one of the most daunting therapeutic challenge for a pediatric neuro-oncologist. Infantile medulloblastoma or medulloblastoma in the young invariably are classified into the high-risk category. All those who have less than 3 years of age and have this tumor come into the high-risk category regardless of their histology, the CSF status, the metastasis presence or not present, and also regardless of the residual tumor that is seen. Why is it so? Because these tumors are clinically and biologically more aggressive, they have higher incidence of dissemination, and craniospinal irradiation, which is a powerful tool to manage these patients, is generally avoided due to adverse neurocognitive sequelae. My talk will be highlighting mainly the histology, the molecular subtypes, and the current paradigm of management. The other important aspects like the long-term outcome, genetic counseling, and future research are also very important for these patients in particular. However, due to lack of time, I will be touching on them very briefly. First of all, the histology of medulloblastoma in young. We are all aware that medulloblastoma comprises of 4 distinct variants, and the WHO 2016 classification has included the genetic subgroups as well, along with the histology patterns that we are all aware of. The Desmoplastic nodular variant, which can be seen typically in the cerebellar hemisphere, has a distinct histology. The MBEN, which can be picked up on the MRI by the grape-like pattern of its tumor, also has a very typical histology, and making a diagnosis of MBEN or desmoplastic has great importance, and I'll come to that. The other variant, which is the classic, is very well known to all of us, and the aggressive form of disease, which is the large cell anaplastic, is not very often seen in infant medulloblastoma. So something which is atypical as compared to the older medulloblastomas, this particular variant is not that often seen in infants. Why is the histology important? Because if you have a desmoplastic medulloblastoma like histology or a MBEN variant, across the board, all the studies have demonstrated that desmoplastic and MBEN fare much better as compared to the other histologies in this subgroup. Also, the presence of metastasis does not significantly lower the event-free survival of patients with desmoplastic or MBEN histology. So histology is very important and we need to get it right. When we come to molecular subtypes of these patients, you all are familiar with this beautiful depiction of the molecular subgroups, that is the Wnt, the sonic hedgehog, group 3 and group 4. When we talk about medulloblastoma in the young, what we mainly focus on is the sonic hedgehog and group 3, because these are the variants which are more often seen in the infantile medulloblastoma. Wnt pathway, as you all can see, is not represented in the young children, and it is not seen in this age group. Group 4 is also represented in a very small amount in these subgroup of patients, and it is mainly the SHH or the group 3 variant that is seen. When we talk about the molecular subgrouping and its correlation with histology, when we talk about the sonic hedgehog pathway, most of these patients actually have a desmoplastic histology, whilst the group 3 and the group 4 mainly have a histology which is similar to a classic medulloblastoma. So they can be, cannot really be used as surrogates, doing a histology and a molecular, both are important, but there is a kind of an overlap that can be predicted based on the histology or on the molecular subtyping. When we talk about metastasis in these patients, most often the metastasis is seen in group 3 or group 4 patients and very rarely seen in the sonic hedgehog mutant young medulloblastomas. Why is this molecular study important? Because again, like the histology, the way the desmoplastic had a good outcome, in this molecular subcategory, the sonic hedgehog pathway mutant young medullos do very well as compared to the group 3 and the group 4. And also, these molecular pathways provide potential therapeutic targets for the future studies, and a lot of studies are actually being done to target some of these pathways to get better outcome for these challenging patients. The challenge of making a complete diagnosis is immense. We need the help of the pathologist, the molecular person. It is difficult to perform all these tests. They are very expensive. They are time-taking. And for the large part of the world, the middle and the lower income countries, these tests are not even available. Even if they are available, they are extremely expensive, and only a couple of labs in a particular country like India are actually doing these investigations. So we still rely largely on the histology and the Chang staging for most of our patients. Can we improve on that? So definitely the immunohistochemistry markers help us to identify sonic hedgehog, the non-Wnt non-sonic hedgehog pathway mutations, and they can act as a surrogate for if you do not have access to the molecular workup. While talking about the infant or the young medulloblastomas, MYC amplification by FISH can be identified in 20% of the group 3 patients. TP53, which is, as told by Dr. Kriti and Dr. Jalali, which carries a bad prognosis in sonic hedgehog pathway mutants, thankfully are not seen in infantile medulloblastoma. So we really don't have to worry too much about the TP53, but MYC amplification in group 3 is definitely associated with a bad prognosis in this age group. The story doesn't end there. When we talk about the sonic hedgehog pathway, St. Jude Young Children study demonstrated that even in sonic hedgehog, we have two subgroups, the SHH1 and the SHH2. Is this really important to evaluate that? These tests are extremely exorbitant to get access and, to get these tests done. The last I investigated, one of our patients, it was costing thousands of dollars to get this test done from Germany. But yes, there is some importance to that. That if you identify a sonic hedgehog 1 mutation in a young medullo, this child is probably not going to do as well as a sonic hedgehog 2 mutated child. So this is what was found in the St. Jude Young Children study. And, it tells us that if you have a SHH1 mutated patient, this child requires a very aggressive therapy and maybe is a candidate for novel agents. So medulloblastoma is no more just a study of histology or the basic 4 molecular. It has now become a disease which comprises of 12 subtypes. If we concentrate on the young medulloblastomas, the sonic hedgehog is sonic hedgehog beta, that is SHH1, sonic hedgehog gamma, which is the SHH2, which carries a better outcome. And the group 3 can be divided into group 3 alpha and group 3 gamma. The group 3 gamma is associated with the MYC amplification and carries a worse outcome for these subgroup of patients. Coming to the management patterns for this, the current paradigm of management is a little complex to understand. However, we need to understand that the challenges in management evolved right from the delay in diagnosis for infant medulloblastomas, and also the fact that these are probably more aggressive biology tumors, and that is why managing them is quite tough. There is increased surgical risk. There is increased toxicity due to radiation. There may be, candidates for undertreatment because of their age. There can be huge amount of long-term sequelae in these patients, and that is why to optimize the management of these patients, we need to start really from the maximal safe resection, go on to avoid craniospinal irradiation, give them an aggressive therapy because they have aggressive biology. At the same time, it should not be too toxic to lead to too much of treatment-related mortality. and very important to focus on to preserve neurocognitive outcomes. The studies on the baby brain tumors started early in 1980s, and it is really fascinating to read about the evolution of chemotherapy for these patients. However, I'm just going to focus at the current paradigm of treatment for these patients. The first and the foremost strategy of managing these patients is the German strategy of the HIT-SKK trials. This is the HIT-SKK 1992 paper, which was published in NEJM in 2005. The chemotherapy backbone for this patient comprised of 3 cycles of chemotherapy. Each cycle had 4 blocks of chemotherapy embedded in it, and there were a total of 36 intraventricular methotrexate administration in this protocol. And that is supposed to be the key element of treating these patients. The study clearly demonstrated that patients with desmoplastic medulloblastoma did very well, and the classic medulloblastomas had a modest response as compared to the contemporary protocols in 1992 to 1995. They analyzed the neurocognitive skills of these patients, and they identified that those who received intraventricular methotrexate did better than the historical controls of patients who received craniospinal irradiation. But this was definitely inferior to those who were just given, that is the control group of the patients who did not receive either intraventricular or craniospinal irradiation. So intraventricular does do a bit of a damage, but we are yet to clearly understand the extent of that. They wanted to improve the survival more. So what was done in HIT-SKK 2000 was the addition of 2 cycles of chemotherapy. However, this was not met with any kind of benefit. It just gave more toxicity to the patients. Surgery, craniospinal irradiation, and 4 cycles of consolidation were added in this protocol for those who were not in complete remission. And as usual, the desmoplastic did very well, but the classic and the large cell did not do well even on this protocol. The latest study from the HIT group, which has been published in JCO in 2020, was an extended validation cohort of the HIT-SKK 2000 patients. There were 87 patients in this cohort. Until 2006, everybody received craniospinal irradiation if they had poor response or if they had progression. From 2006 onwards, local radiotherapy was introduced for non-responders or those with classical or anaplastic histology in an attempt to improve the outcomes. What happened to these patients was a little surprising, that despite local radiotherapy for these patients, their outcomes did not improve. So the classic and the anaplastic continued to do poorly despite local radiation. It was also observed based on the molecular profiling that group 4 patients did better than group 3. Further analysis of this particular cohort, the reason for why this local radiation did not show improvement in these patients was the fact that instead of local relapses, these patients started developing metastatic relapses. So eventually the outcome was quite poor for this particular cohort of patients. Interestingly, this group also looked at the SHH1 and SHH2, and in contrast to the St. Jude study, did not find much difference in the outcomes between SHH1 and SHH2, although there was a trend towards the inferior survival of SHH1. So the jury is still out about whether molecular profiling to this extent is required for every patient or not. The second way, after the intraventricular approach, the second way of managing these patients in the current paradigm is the usage of autologous transplant. The Head Start studies started early in 1991, showed that usage of 5 induction chemotherapy cycles followed by a second look surgery and a myeloablative chemotherapy and an autologous stem cell rescue led to good, a reasonable outcome in non-metastatic patients. However, those with a residual disease continue to do poorly despite an autologous transplant. This protocol did not use intraventricular methotrexate. There was no cranial RT. There was better neurocognitive outcome. However, they did observe toxic mortality. And doing this practice in a low and middle income country, we need to be very sure of our infection control and infection management strategy to avoid toxic deaths in these patients. The recently published Head Start 3 protocol, published in Neuro-Oncology in 2020, also used 5 cycles of induction. However, this time, high-dose methotrexate was added in this induction protocol. Following that was the second look surgery if a patient needed it, and a myeloablative stem cell transplant. What did this study show? Again, histology is the main factor, and the Desmoplastic did much better than the other histologies, even in this protocol. End of induction response status showed that if you have a residual disease, you are likely to do poorly. So we got excellent results in patients with the Desmoplastic or the sonic hedgehog with both the intraventricular and the high-dose chemotherapy strategy. So the dilemma in front of us is, can we decrease the treatment burden for these patients, and can we further improve outcomes for those who have aggressive histology or molecular subtypes? Unfortunately, the therapy reduction did not work. The St. Jude study or the ACNS 1221 study were met with poor outcomes as compared to the HIT SKK and Head Start similar protocols of the similar type of histologies, and it was thought that we will not be able to do well without using an intraventricular methotrexate or high-dose chemotherapy for these patients, and aggressive therapy is what is required. However, there is a case that if we definitely say that SHH2 are going to do well, there may be a case of therapy de-escalation in a proper clinical trial setting. The average risk will require either of these two strategies, and the group 3 and the group 4 will need very intensified therapy and maybe novel agents or immunotherapy to get better outcomes. The ones with extensive metastasis probably go on to either the palliative way or go on to the experimental treatment strategies. Late effects is a very important aspect of these patients, and neurocognitive assessment should be a part of each and every trial and each and every clinical patient that we manage in our day-to-day practice. We may come across certain patients like this one, who had a large medulloblastoma with a desmoplastic histology, a sonic hedgehog pathway mutation, and just, while treating this patient, the mother was getting operated for a dental cyst. And at that point of time, we evaluated the patient and identified a Gorlin syndrome and a PTCH mutation leading to that. So, these patients are candidates for genetic counseling, and a very careful look at different types of syndromes is an important part when we manage infantile or young medulloblastomas. The other syndromes like Turcot syndromes, the SUFU mutation, SMO mutations, and PTCH mutations have also been identified in these patients, and they are probably potential pathways where targeted therapy can be used in future to optimize the outcome of these children. To summarize, medulloblastoma in young comprises of two main subgroups. Group 3 do extremely poorly, especially in the presence of metastatic disease. SHH non-metastatic do well, and even the metastatic, there is a potential for cure in those patients. High-dose chemotherapy and intraventricular methotrexate are good strategies to avoid or delay radiation in these patients, and novel approaches, targeted therapies are needed to improve short and long-term outcomes. Thank you.